Just to start with, thanks Dr. Avinash and also Dr. Avin from Arunachal Pradesh. And last but not the least, I should not forget about Professor Kapoor, our mentor, who gave
Yes, sir.
this idea of starting this program. And I love to do so also. So, with all your help, and probably say this is just the beginning, and we will be coming up with more students being added. I believe that Arun, you must have shared to your juniors also. Did you share it with the seventh semester?
Yes, sir.
Okay. So if they will be joining also in between, no issue. So we'll be covering up. See, this venous diseases must have been taught to you in your theory class, and probably you must have seen few cases of this venous diseases in the OPD. Why am I telling? Because if you see the northeast belt, the venous diseases, its consequences, its complications will be little rare as compared to that present in the different part of India. So we do see more number of cases of these venous diseases in our OPD with all its complications. Though that is why it is prudent that I thought I should share my experience and knowledge regarding venous disease to you all. And as you know, the venous diseases, if you see, will be asked to you as a long case, long question in the theory exam, and also it will be just also it will be short note the application. So you'll be getting all varieties of these questions. Is my PowerPoint still visible? It disappeared.
Your PowerPoint has become like half.
Just a minute. I did some problem actually. So I thought it is prudent that I should start with this venous disease because if you see the venous disease, we do see a number of cases of this venous disease in our OPD with all its complications. So my audio is also clear. I'll go rather very slow today. My audio is clear, or I should put my this earphone.
Yes, sir. Your audio is clear.
Okay. I think we will be just not continuing for at a stretch for 1 hour. I'll be just taking this class on the theoretical aspect of the venous disease. Next time, next week, I'll be teaching you about the. I'll be showing you a video and also the clinical examination part of a varicose vein case when they will be coming to your OPD. Okay, because it is prudent that if you do not know the theory, then it will be little difficult for you to know the again the clinical aspect. So, with this brief introduction, diseases of the peripheral venous system, let me just go one by one. Before any surgical topic is contemplated, as you all know, we should always start with the anatomy, then physiology, then we come to the pathology or pathophysiology, then surgery. So, here also the same thing. The anatomy is although boring, but it is interesting. You need to have a deep interest in it, then only you will be enjoying it. The leg vein anatomy, if you see, it is made up of two network of veins. One network of vein is the superficial venous system. One network of vein is the deep venous system. And this deep venous system will be continuing upwards to drain to the IVC, to the common iliac veins, then to the heart. Thereby the circuit is completed. Now, what about the superficial venous system? If you see the superficial venous system, actually, it drains also the entire lower extremity. And my class is basically on the lower extremity. It will be draining the blood from the lower extremity also, but it will be not connecting to the heart directly. It will be connecting to the deep venous system, and via the deep venous system, it will be just going upwards to the IVC and thereafter. So, with this brief introduction, let us now find out what is the actual origin of this superficial and the deep venous system. Superficial venous system and the deep venous system, if you see the deep venous system first, let me start over here. If you can see my cursor, or I can also take there will be also a cursor. Okay, so if you see over here, mouse. So if you can see my cursor over here, so the deep venous system will be accompanying the arteries like the anterior tibial artery, the posterior tibial artery. Thereafter, it will be continuing upwards as the femoral, along the femoral artery. So the deep venous system will be named as per their arterial system. But the superficial venous system, if you see, it takes its origin from a dorsal plantar venous arch. You can mark over here this U-shaped structure over here. This dorsal plantar arch, if you see, will be continuing medially upwards behind the medial malleolus over here and as the great saphenous vein. This great saphenous vein will be continuing upwards like this along the medial aspect of the extremity, and thereafter it ascends upwards along the medial aspect of the thigh to drain into the femoral vein through the cribriform fossa and the saphenous opening after it enters into the deep fossa level. Similarly, the lateral aspect of this plantar arch, dorsal plantar arch, continues above behind the lateral malleolus, as you can see over here, behind the lateral malleolus as the short saphenous vein to drain to the popliteal vein. So, superficial venous system is the great saphenous vein and the short saphenous vein in brief. Besides these two opening, if we see, another opening is also there in between, rather multiple openings are there between the superficial venous system and the deep venous system, which will be communicating the blood from the superficial system to the deep system. They are the perforators. So these perforators, if we see, will be also having the structure like this. In this diagram, if you see schematic diagram, this is the deep venous system, this is the superficial venous system, and they do have valves in between. So these valves will be preventing the backflow of the blood from the deep venous system to the superficial venous system, but it allows the blood to flow from the superficial rather to the deep. So these valves are essential for maintaining the um, anatomical stability, physiological stability of the superficial venous system. Whenever there is any problem with these valves, whenever there is any problem with the deep venous system, expected there will be a heavy load of pressure on the superficial venous system. With this brief introduction about this, we will be going to the varicose vein and why it is again present. So, venous pressure in foot vein on standing, mind it, is approximately 100 millimeter mercury. So, this tremendous pressure generated. So, during walking, jolting, it increases to 200 to 300 millimeter mercury. So, if there is any blockade at any level, that means deep system or the perforators, or there is a reflux of the blood from the deep system to the superficial system, especially during the walking, during the jolting exercise, there will be any backflow of this blood to the superficial venous system. That causes actually dilatation and tortuosity of the venous system, that is called as a varicose veins. Pressure in the calf compartment rises to 200 to 300 millimeter mercury during muscle contraction. As I told you, this is often a MCQ asked. Now, anatomy I have discussed, but see, if you see the schematic diagram over here, there are multiple other veins, and many times also you'll be finding in your clinics that beside the great saphenous vein and the short saphenous vein, also multiple other veins are also visible anteriorly over the sheen of the tibia and posteriorly also on the calf and the thigh. What are those veins? They are called as the communicating veins. So anteriorly it is the anterior communicating veins, posteriorly it is called as the posterior communicating veins, and these posterior communicating veins, when it will be present in the thigh level, then it is called as a vein of Giacomini. So this is often also MCQ asked in your entrance examination. So what is the vein of Giacomini, where it is present? So with this anatomical introduction, let us go to the physiology. Something also interesting, but also we should know as a surgeon over here. You can see nerves below the knee joint from the calf region, just getting very closely associated with that of the venous system. So along the great saphenous vein, it is the saphenous nerve. Along the short saphenous vein, also the sural nerve will be accompanying. So believe me, we should be very cautious while dealing with the varicose veins below the knee joint. So any stripping should be done above the knee joint. If it is done below the knee joint, then the consequence you must have realized by now. There will be tremendous pain. Also, there will be anesthesia because of the damage of the sural nerve and the saphenous nerve, which is closely associated with that of these varicose veins or the venous system. Now, what is the varicose vein? If we see the definition of the varicose vein, it is the dilatation and tortuosity of the venous system. So, dilatation, obviously, if there is an increased in reflux of the blood from the deep system because of XYZ reason, as I will be discussing, so there will be heavy just reflux of this blood from the deep system to the superficial system. To accommodate this extra blood, the vein gets dilated. And suppose you look towards my two fingers. If the vein is this, both my palms are the venous valve, and this one is the valve over here. So if the veins get dilated, as you can see, the valves will be completely inefficient in their function. So the veins first becomes dilated because of the reflux of the blood from the deep system to the superficial system via any of the perforator or the saphenofemoral junction or the saphenopoppliteal junction. Thereafter, it becomes tortuous. This dilated vein becomes tortuous because tortuous vein can accumulate more amount of blood as compared to that of a straight vein. So that is the nature's adaptation rather. But overnight, the varicose vein do not appear. So they must be first appearing as a spider veins or called as the telangiectasia. If you can see my cursor over here on the right image, they are the, to start with, they are the telangiectasia. That means these are the veins which are less than 1 millimeter in diameter. Thereafter, what happens? It dilates further to form the reticular vein, which is 1 to 3 millimeter in diameter. Thereafter, if the pathophysiology still persists, then it will be a varicose vein, which is more than 3 millimeter dilated and tortuous superficial vein. So that is also a question very often asked. So what are these telangiectasias, reticular veins, and the varicose veins? As I was showing you in my hand, so this is the same example over here. If there is an inefficient valvular function, it leads to reflux of the blood via the superficial system from the deep system. So if we see another entity also over here, chronic venous insufficiency. Many times what happens, we often see patient may not be having a visible dilated tortuous vein, but the symptom of a varicose vein, just like heaviness in the legs or cramps in the legs towards mostly marked towards the end of the day. And if you see the profession, they may be tram driver, they may be bus conductor, they may be even housewife standing and cooking in the modular kitchen for prolonged time, and the traffic police, they'll be complaining that I am having heaviness in my extremity, lower extremity at the end of the day, and I am feeling restless. And you will be thinking, is it a chronic venous insufficiency with hypertension? So what is that? Occurs when the vein valves becomes dysfunctional and impairs venous blood return, resulting in ambulatory venous hypertension. So the term we can use, it is a ambulatory venous hypertension. Affects up to 20% of the adults. And by age of 50, 40% of women and 20% of men have significant venous problems. More people lose work time from vein disorders than from arterial disease. So with this, what are the different risk factors? Rather theoretical, we should also know. Advancing age, family history, ligamentous laxity, that is hernia, flat feet, prolonged standing, increased BMI. Obese people do have more predisposition for varicose vein, which I very often see, and smoking, sedentary lifestyle, lower extremity trauma, prior venous thrombosis, superficial or deep venous thrombosis, arterial shunt, hereditary conditions, or high estrogen states, or pregnancy. So these all conditions are the etiology or risk factors rather for the development of varicose veins. So, if you see the pathophysiology now, so physiology done. Pathophysiology, if you see, it is either the obstruction of the deep venous system. So there will be obviously obstruction means it will be refluxing back into the superficial system. Thereafter, the superficial venous system will dilate and become tortuous. So the first one is obstruction. Obstruction of what? Deep venous system because of either deep vein thrombosis or XYZ reasons. We are not now concerned about it. Second one, reflux. As I told you, sometimes what happens if you see the etiology, that means there is a defect in the matrix metalloproteinases, or that is a systemic disease which will be dilating the veins. That means the venous wall becomes weak and it dilates. So if it dilates, obviously I showed you in my hand again the valvular system cannot approximate efficiently, which leads to reflux. So it can be obstruction or it can be reflux or it can be both, which is the pathophysiology behind the varicose vein. So anatomy we have discussed, physiology we have discussed. Now pathophysiology also we have also started, and the concept is now clear probably. Current concepts in pathophysiology of varicose veins, because in the recent advances you may be asked a short note regarding it. What are the recent concepts? DVT obstruction, yes, initially always was also thought, and this is also thought to be the significant factor leading to a varicose vein. Second one, older theories was that valvular failure lead to venous reflux and venous dilation. But why there will be a valvular failure at all? So valvular failure may be that the thrombosis must have extended to the superficial system from the deep system, and during the phase of recanalization or this thrombus becomes the thrombus melts, then these valves become again inefficient. That may be a leading cause. But the newer theories are accelerated tissue aging. As I told you, the walls become weak. Matrix metalloproteinases induced weakening of the endothelium and smooth muscles of venous wall, leading to venous dilation and valvular dysfunction. I hope I am clear till now. Something you must have seen in the Bellila, that is the CEAP classification, just like the TNM staging. We have this CEAP classification. This is often also a question asked in the theory. What is the CEAP? It is very simple. CEAP means first one is the clinical, then E is etiological, A is anatomical, P is pathophysiology. So just don't get confused by this big definition or classification. So if C, it is very easy. C0, no evidence of any venous disease. So why the patient comes to you? Maybe ambulatory venous hypertension or chronic venous hypertension. C1, telangiectasia reticular veins. As I showed you in the anatomy, first it will be starting with the spider veins, telangiectasia, thereafter reticular veins, thereafter varicose veins. Slowly, if you ascend upwards, C2, that is varicose veins. C3, edema associated varicose vein. So varicose vein, what happens? Most of you must have marked. Patients will be with varicose vein coming that I am having ankle edema, mostly marked in the late evening, and in the morning time when I wake up, the edema disappears spontaneously to start again in the evening time next day. So probably it is the ambulatory venous hypertension, chronic venous hypertension, which is causing this movement of fluid because hydrostatic pressure into the interstitial space. So edema will be the next complication which arises in a varicose vein untreated. If this edema and varicose veins are left as such and the insulting factor is persistent, what will happen? It will lead to pigmentation or eczema, which we will be seeing also seen over here. You can see slowly and slowly there will be brownish black pigmentation over the ankle area. It is called as also the gaiter area. Gaiter means the soldiers used to put on the lower extremities when they go to the field on the horseback. So this gaiter area, if you see, there will be pigmentation. Wherever there is pressure, there will be this blood becomes extravasated and this hemosiderin deposits in the tissues to form again blackish or brownish pigmentation. This pigmentation often induces inflammation in the interstitial space or tissues, leading to a dry steatosis type of eczema. And we must have marked it is a scaly and it is shiny type of eczema. I'll be showing you also a photo of that. The C4B, if we see that overall entity pigmentation, dry steatosis is called as a lipodermatosclerosis. That is the next complication which will be arising out of this neglected case of varicose veins. Now, C5 is healed venous ulcer. See, if we neglect this lipodermatosclerosis, what next complication will occur? It will be a trivial trauma, or as such, it will be starting with a small eruption and thereby it will be leading to ulceration. And these ulcers are refractory to treatment. They are non-healing ulcers, refractory to treatment. For we see patients having these ulcers for over 2 years, 3 years, or even more than that. So it will be refractory to healing. Why? Obviously, you know the reason. So we have to treat the underlying cause for the ambulatory venous hypertension that will lead to cure of these all complications. If you target only the ulcer, then seldom that the ulcer will be healing. Whatever treatment you give, whatever injections or ointments you give, it won't heal at all. So with this knowledge, now C0 to C6, that is the clinical one. What you see in your OPD. Something we need to again ask or introspect why it occurred. That means etiological. It may be congenital. Sometimes the venous, I told you, there will be dilatation. The valves won't be functioning efficiently, which will be leading to reflux. Or it will be a primary venous disease or a secondary venous disorder to some other complication like pelvic tumor, pregnancy, secondary causes, or secondary to DVT, or etiology not specified. Anatomy, it will be the superficial veins dilated, deep venous system dilated, perforators insufficiency are not specified. Now, P is the pathophysiology. As we discussed from the very beginning, anatomy, physiology, then pathophysiology. It is either the reflux, it is because of venous obstruction, or both reflux and obstruction as the etiological agent. Progression of a venous disease. As I told you, now you can see in the schematic diagram, or rather the photographs of the patients over here. In the beginning, there will be no venous dilatation, only aching or heaviness towards the end of the day, swollen legs, restless legs. Superficial venous dilatation thereafter ensues. As I told you, it will be a spider vein over here, you can mark. Then it will be the reticular veins. Telangiectasia to start with, it is less than 1 millimeter. Then it is reticular veins, dilated, non-palpable subabdominal veins. It is 1 to 3 millimeter. Varicose veins will be more than 3 millimeter in diameter. So other complications or anatomical findings are saphenous varix. Saphenous varix is nothing. It is the differential diagnosis of inguinal hernia. It will be just only dilatation of the and tortuosity of the three tributaries of the venous system, which will be joining the great saphenous vein at its insertion to the femoral vein. I am talking about the superficial epigastric, superficial external pudendal, and the superficial circumflex iliac, three tributaries. These often gets dilated tortuous to give a feeling as if it is an inguinal hernia or a femoral hernia present in the groin. Then atrophy blanche, corona phlegmaticasia, pigmentations, lipodermatosclerosis, ulcerations. We have already discussed atrophy blanche and corona phlegmaticasia. I will be discussing. Differential diagnosis, of course, if it is ambulatory venous hypertension only, then we should rule out rheumatology related, orthopedic related, neurological related, or it can be lymphatic also obstruction lead to edema, venous edema, and the different problems also are clear related because pain is associated. We should also rule out ischemia. As I showed you in the beginning, it will be leg edema if untreated. It will be a pitting type of edema, disappears in the early morning to reappear in the evening. Then hyperpigmentation starts. So you can see over the gaiter area, this lower area of the leg is called as the gaiter area, Gaiter. Then chronic venous insufficiency can lead to the skin change as stasis dermatitis. As I told you, lipodermatosclerosis. If you see, the dermatologist frequently will be misdiagnosing it as a just a simple eczema and will be going on giving steroids. So even if you give steroids, it may work and the ulcer or this lipodermatosis may improve to reappear again when you stop it. So we need to know the cause and treat it, the root cause, rather than only the symptom. The skin changes, if you see corona phlegmaticasia, that is venous cause Altogether, they are called as the corona flebectasia. Then lipodermatosclerosis forms often a paniculitis just above the ankles. As you can mark over here, the upper part of the thigh or the calf region will be swollen up, but because of the paniculitis inflammation of the lower part over the ankle area, it becomes thick and fibrosed and do not yield to edema in the future. That will give appearance of inverted champagne bottle appearance. That is inverted champagne bottle appearance, classical of a venous disease. This can lead to stasis ulcer, as you can see, and usually the venous ulcers are mostly present over the medial malleolus. Now, the difference between the arterial ulcer and the venous ulcer, you all know just a few lines about it. If you see, mostly they are located the venous ulcer or the medial malleolus, whereas the arterial will be present throughout the feet rather you can be specific lateral malleolus. Then pedal pulses will be diminished in arterial one. Pain will be excruciating in the arterial ulcer, and drainage, if you see, venous ulcer, because of congestion, there will be profuse discharge, whereas arterial ulcer will be almost dry. So, evaluation of a venous disorder. First is a clinical examination, which I will be taking time half an hour. Next class in subsequent week, I will be teaching that. So, clinical examination by phlebological test we should know, and it is very easy. Only simple test you can confirm your diagnosis and go in for treatment. Then to confirm it by radiological means, the continuous wave handheld Doppler examination, I will be telling something about it. The third one is the duplex ultrasound imaging, which is both anatomy and the physiological evaluation done by an ultrasound machine. Then varicography, which is not used frequently, only theoretical one. Clinical and handheld Doppler misses reflux in 30% of cases. So in those cases, actually, this duplex ultrasound imaging or very, very rare, the varicography may help in detecting these 30% of cases. But varicography is not done frequently, so duplex ultrasound is the best investigation modality rather for detecting any reflux. Clinical evaluation, I am not coming now, we will be just discussing in the next class. Now, once clinical evaluation is done about the superficial venous system, thereafter we need to ensure by radiology whether there is any reflux present or not, where is the reflux, where is the pathophysiology, and whether the deep venous system is working or not, which perforator is incompetent. Before this perforator, rather I should ask you a few questions. What are the named perforators along the great saphenous vein? So if you see the named perforators along the great saphenous vein, starting from above, first one is the saphenofemoral junction area. Then below, you have the adductor or the Hunterian perforator in the adductor canal area. Just above the knee joint, it is the above knee one or the Dodd perforator, Dodd, D-O-D-D-S. Below the knee joint, you have the Boyd perforator, B-O-Y-D, Boyd's perforator. Just above the ankle region, you have the pocket 1, 2, 3. That is present around 15 centimeter, 10 centimeter, 5 centimeter above the medial malleolus, pocket 1, 2, 3 perforator. In the foot region, we have the May or Kushner's perforator. So these are the named perforators present along the great saphenous vein. God is kind enough not to name any perforators if at all present along the short saphenous vein. So theoretically, there are practically no perforator veins excepting the saphenopopliteal junction on the lateral aspect. Now, once phlebological tests are done, you have a doubt, yes, probably it is a saphenofemoral junction along with this perforator which is incompetent. We need to ensure it by the radiological means. First one is the venous duplex ultrasound. What is the duplex ultrasound? Evaluate for both deep and the superficial venous thrombosis. Evaluate for incompetent veins with significant reflux. As I told you, duplex ultrasound, that means it uses a B mode ultrasound which gives a black and white image of the venous system. Along with, if there is a reflux, there will be a color code. If it is towards the heart or it is away from the heart. Away from the heart, it gives a red color, and as you can see in the diagram over here, and towards it will be blue color. So whenever there is any reflux towards the probe, that means there is a reflux. It will be red appearance. You can very well see on compressing the veins above the probe if there is a reflux present in the perforator vein or not. So that is called as a both anatomy of the vein, that is dilated or not, tortuous or not, along with reflux, that is physiology, can be detected by means of this Venous duplex ultrasonography. So we should always tell investigation of choice is rather the Venous duplex ultrasonography. Now, management of the chronic venous insufficiency, if you see, management comprises of asymptomatic disease, what to do, then symptomatic. Symptomatic, mostly they come to us with complications. So I'll be covering up only just briefly, I'll be discussing about the management portion because this is more theoretical. You can go through in your textbook. So most of the cases, if you are diagnosing that leg cramps, towards the end of the day there is leg edema, ankle edema, or you are suspecting that it's a case of ambulatory venous hypertension, but there is no evidence of any varicose veins, you can give assurance. You can ask maximum to go in for conservative treatment. What are those conservative treatment? We will be discussing about those. Now, treatment in the complications, three C's. Three C's are either complaints, complications, or cosmesis. Complaints, as I told you, pain, there will be edema. Complications, we have already seen discussed, that is lipodermatosclerosis, pigmentations, ulcerations. Mostly they come to you with refractory ulcers, non-healing ulcers. Cosmesis, obviously nobody will like their lower extremity, that is the visual portion, to be just having a discolored limb with ulcers and with champagne bottle appearance. It looks very odd. That is why for cosmetic reason. Most in C2 disease with bleeding superficial thrombophlebitis or C3 to C6. That means most of the patients do come to you with C2 disease onwards. That means appearance of the varicose vein. So they will be coming to you that Dr. Zava, I am thinking there is some problem in my extremity. I can see dilated and tortuous veins. Thereafter, the various stage and complications. So first treatment is always a reassurance. Just reassure the patient that it is nothing to worry. It is because of your profession. It may be because of your structure, anatomy, or it may be prolonged standing. So you must be just advising him some tips which will be helping the patient in order to just have a control of the disease. Then second one, compression. As I told you, friend, so if it is the extravasation of the fluid, so if you compress it, this interstitial fluid will be moving back along the lymphatic system and forced back to the vascular system. So this edema will be just disappearing or it will be controlled. Pharmacological, I will be telling something about the pharmacological aspect, surgical and the minimally invasive modalities also. Now leg elevation. All the patients do advise one thing at least, or in your exam you advise that you just while sleeping, you can raise the lower extremity by putting pillows, one at the knee joint level and one over the ankle region. So the lower extremity will be just elevated while sleeping, just as you can see in the schematic diagram over here. Now, with this position in the patient sleep, the edema will be disappearing. Most of the complications will be arrested from increasing. That means if there will be ankle edema, it won't be causing this pigmentations or lipodermatosclerotic changes if every day the person will be just sleeping in this way, because the dependent portion, whatever the blood is collected, will be again just flushed back. Exercise daily, walking and simple ankle flexion exercise. This is a myth that all the patient will be thinking, I am overworking, that is why I am having this venous disease. So you should assure them, no, exercise should continue because the gastrocnemius and the soleal muscle pump, they should be actively pumping the blood via the deep venous system to the heart. So if there will be exercise, if there will be daily walking, it will be definitely helping the patient in moving the blood in the forward direction. If there is a deep vein thrombosis, just ask the patient to take rest, not the reverse which I was just advising. If you see, pleiotropic drug, I am not going into all those pentoxifylline, several drugs are a calcium, dovasilate, all these mechanisms, these are all pleiotropic drugs. What is pleiotropic drugs? These are nothing. These are only causing this contraction of the vein. As I told you from the very beginning, if the veins becomes dilated, the lumen becomes dilated, there can be reflux because of the valvular insufficiency. So by whatever means pharmacology, If you just constrict the vein, it may work. So only known drug which will be working efficiently is the micronized purified flavonoid derivatives, MPFD. That comes in the combination of this diosmin, hesperidine, butene, and the leukocyte. This is a plant product, and probably it is obtained from this orange peel, and it is micronized, and it is usually imported from outside, and it works efficiently as a venotonic. That means it will be maintaining the tone of the venous system. That works also efficiently. The different dosages are 500 milligram or 1000 milligram. Usual recommendation in average adult is 1000 milligram once daily for 2 to 3 months, and the patient will be improving his system, the venous system, and the ulcer, refractory ulcer, may show signs of healing. The other aspect is skin cleansing, applying emollients, barrier preparations, topical corticosteroids usually may be also treating this stasis dermatitis, but this is transient. We have to treat the cause for it. And if there is a lymph edema and all this, compression therapy, as in case of lymphedema, also is advised over here. That is why the concept of putting stockings, elastic graded stockings, are also a treatment armamentarium in case of venous insufficiency. It comes in class 1, class 2, class 3. Class 1 is simple 20 millimeter, class 2 is 30 millimeter, class 3 is 40 millimeter, 20, 30, 40 millimeter mercury pressure they attend. Mostly they come as below knee, but above knee also stockings are available. But above knee stockings are very cumbersome for the patient to put it on. That is why patient compliance is very poor in above knee one. Usually we advise the below knee compression stocking. So while ambulatory, while going to work, the patient will be putting on these stockings. While sleeping, patient will be removing the stocking, will be elevating, keeping their limbs in the elevated position. That will be helping in control of the disease. So if we come to the treatment, I think so we should stop over here. The rest surgical treatment and the various this sclerotherapy and all this. Next class, I will be talking about this first the phlebological test. Thereafter, I will be going in for the treatment aspect, so that will be interesting. I should not drag for more than half an hour. I believe so.
Thank you, sir.
Okay, any doubt? You can ask me. Any doubt, you can ask me.
हेलो गुड इवनिंग सर
Yeah, good evening, good evening. Good.
सर ये जो लेपोडर्मेटोस्क्लेरोसिस था ना सर उसको जो
Yeah,
इन्वर्टेड शैंपेन बॉटल अपीयरेंस सर लाइक वी से नो सर
yeah.
again that this appearance also said as inverted beer bottle appearance.
Inverted beer bottle appearance.
Yes sir.
Same thing, beer bottle, champagne bottle. So, but in the if you see the literature, it is the champagne bottle. Same thing, huh?
Yes sir.
So the calf becomes will be actually voluminous or dilated, whereas the ankle region, if you see, it is constricted. Inverted bottle appearance. Whatever you like, you can tell. So, any more doubt till now? I believe that I have cleared all everybody's concept. So, what is there and why it occurs? Because you should know this anatomy physiology before jumping for the phlebological test. Because if you do not understand the pathophysiology, then it is useless for me to just tell about the phlebological test.
Hello sir.
Yes, yes.
Yes, sir. Sir, actually I have one doubt.
Yeah, please.
Sir, in patients who have deep venous thrombosis,
Yes.
can exercise improve that varicose symptoms of varicose veins?
Deep vein thrombosis, having varicose veins, you are telling that?
Yes sir. Can exercise
Yes,
improve that symptoms?
See, what happens actually, I told you, either there will be obstruction of the system or there is reflux. So, in case of deep vein thrombosis, to start with, it is the pressure in the deep vein which will be because the blood is not flowing from the in the deep venous system. So, the blood will be not going from the superficial to the deep. So, there is a pressure built in the superficial system. So, there is usually dilated and tortuous veins. Also, even if there is no deep vein thrombosis, there can be superficial thrombophlebitis also associated in case of varicose veins of the superficial venous system. So those can also intermittently manifest as pain, localized edema, localized this reddening of the skin. All features of infection will be also present. So thrombophlebitis superficial thrombophlebitis is also found in case of varicose veins. Did I just answer your question or still?
Yes, sir. But in cases of the deep venous thrombosis, the patient usually complains of bursting pain while
Yes,
walking, as
yes,
it's mentioned in as DAS surgery. And
yes.
in if we advise him to exercise, shall it will not give more pain to the patient.
No, 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 I did not tell to exercise. I told you probably missed it. I told if there is no deep vein thrombosis, then you advise the patient to do walking every day. So that what happens, the blood circulation should be continuing. But if there is a deep vein thrombosis, never advise so. It is the reverse. Take rest. Okay.
Okay.
But
Yes, sir.
believe me, you will be seeing patients not with acute deep vein thrombosis with the varicose veins. They will be having some thrombosis in the past which got again unnoticed, manifesting as reflux and slowly with varicose veins. Suddenly there will be deep vein thrombosis and there will be varicose vein. Is it possible? Theoretically not possible. Got my point?
Yes.
So there will be a thrombosis in the past which went unnoticed. Maybe that there must be some occlusion which got unnoticed, and after a trauma or so, road traffic accident, then the patient will be manifesting as varicose vein. When we put on the Doppler ultrasonography, we'll find the deep vein is partially occluded or fully occluded. So those will be the scenario when they will be walking to your OPD. Otherwise, they'll be walking to where? They'll be going either to cardiology or cardiothoracic, not to the surgery, general surgery. Got it?
Yes, sir. Thank you.
Yeah.
Hello.
Yes, yes. Coming,
So,
bro.
actually, sir, this is my last question, sir.
Yes.
In case, no, sir, I am suspecting that my patient have increased chances of having like embolism. No, so, sir, I think what are the tests that I should not do in this patient? Like, there are certain tests to rule out DVT, no,
Yes,
sir,
yes,
like
yes.
comments, like
Coming, bro.
what are
See,
the
see,
criteria I should not do to?
see, good thing, good thing. See, next class, that is why I am just putting this inquisitiveness in you all. Please go through the belly law textbook on the chapter on venous disorder. I am hoping that all will be going through the chapter. Next class, I'll be showing you the phlebological test. I have a beautiful video, clinical demonstration of those phlebological tests, which will be very easy. Thereafter, you will be understanding the concept and also for the deep vein thrombosis, how to rule out those tests, Moses test, Homan's test. So I'll be also showing you those. Don't worry.
Okay, sir. Thank you, sir.
Okay. So if there are no more questions, I think you should call it a day. And I'm expecting all you go through the textbook at least this week. Next Saturday we'll be meeting and completing the chapter on this, and also I'll be showing you the clinical demonstration of the varicose veins. Okay.
Yes, sir. Okay, sir. Thank you,
Yes,
sir.
yes.
Okay.
Thank you, sir.
Thank you, Dr. Avinas. Thank you.
Thank you.
Thank you, sir.